goes. I'm sorry. Who was saying what?
Is Carly. The one thing I do want to say is that when we open up the initial phone encounters, they look nothing like the preview screen that we're looking at right now.
So does it automatically default for you to like an OB telephone encounter?
Yes. So we have individual schedules that we run off of with nine patients a day.
Yeah, exactly. So what you'll want to do, I have that as one of the things that we'll need to set up, is go up, see the button up at the top of the bar that says encounter? So on the very top.
Oh, yes.
Yeah. Mm-hmm. So instead of, not telephone encounter, but do encounter.
Okay.
And then drop, I guess you'll have to choose her again. And then you should be able to put new over there.
Okay.
And then you should be able to put in like OB telephone or scroll down. Yeah, telephone appointment visit. And then I don't know if you can put in your, health credentials and then GYN. And then this will hopefully take you to a screen that looks a lot more familiar to you.
Okay, let's see. Oh, that's a lot more stuff than I usually see. Okay, that's good enough. Go on for this. Okay.
Gosh, look at that past medical history.
That's a rough one.
That's
you
a lot
probably
to go
don't
through.
usually see that.
No, not at all. But, Okay. So when you just want me to start from beginning to end on what we do with the patients on the phone, or what would you like me to do?
I would like to know even the pre-work.
Okay.
I'm curious to know at what point the online questionnaires get the information actually gets incorporated into the chart. If that happens when you create the pregnancy episode, if it happens, where's the magic happening on that one?
Okay. So just recently they let us start sending out the OB history form, or, the patient's medical history form that gets attached with the 3 questionnaires that we do, which would be the early start screening questionnaire, the ethnicity-based screening questionnaire, and the genetic screening questionnaire that gets sent out to patients. So it's 4 forms total that we send to patients. And when we send them, it really just depends on when they book their appointment. So if we're lucky and we have a patient that books an appointment 2 to 3 days before their actual visit, then we look at our schedules ahead of time and we send out mass emails at the end of the day, usually, when we see patients that need to have the information sent. When it is sent back to us, in an ideal world, when they fill out their paperwork and send it back, it alerts us in our inbox. So the 3 forms, the genetic screening questionnaire, the ethnicity-based screening questionnaire, and the early start screening questionnaire, those 3 forms automatically populate into the patient's chart once we open up the prenatal episode.
Okay, so the pregnancy episode has to be created before that information gets pulled in?
Yes.
Okay.
We can look at it. We can see it in our inbox.
Right.
But we don't need to necessarily accept it or anything like that for it to magically appear in there. But once the episode is created, then that information will be in there for us to look at.
Okay, and when you say that you're sending out those emails with the questionnaire, at the end of the day, are you primarily responsible for your own schedule and your patients, or do you do cross coverage, or how do you guys actually work that with all of these emails to be sending?
That's a great question. So usually we are responsible for our own that go out. Oftentimes, though, with the other prenatal clerks, we jump schedules depending on who's covering what day. So we are all attached to each other's inbox.
Okay. And I saw someone had shared with me, Cindy did. She shared with me the step-by-step instructions that had the dots and the other things, which is key, I think, to you guys having a sane workflow to understand where patients are at in the questionnaire process.
And it is literally, I looked at it before I sent it to her just to update, the little things that have changed in our process. It is literally step by step every single thing that we do, from point of phone call to when we hang up with patients and what we do after we're done.
That's super helpful. Thank you for sharing that.
No problem. The only thing is, with the past medical history questionnaire, we have to go in and accept that in order to see the results of it. So, like this patient that we're looking at right now with this gigantic history of things, this will not appear to us unless we go in and accept it. So that is the one form that we need to put in, reason for, visit type of thing, and then we accept the information. If there's anything that's conflicting in the patient's chart as far as what they filled out versus what we have on file for them, we go through with them on the phone. So every single one of the forms we're looking at, even if the patient's done them online or if we're asking them the yes or no questions while they're on the phone with us.
Okay, got it.
Okay.
And before we get into the actual phone call, say you're not successful in reaching her, what have you guys established as your workflow to try to reach out to the patient, say she no-shows, or and say there's nothing in the chart to say that she already miscarried or changed her mind and decided to stop the pregnancy, or...
Right. So what we do is we call 3 times, and we wait 5 minutes in between each call. And at the 3rd phone call, the 3rd attempt, we leave a message that they need to rebook their appointment through the call center, and we give them the call center number. We never give them direct numbers here because you'll get a patient that calls you 3 days later trying to get a hold of you to get her paperwork done.
Right.
And so we kind of put the ball back into the patient's court to say, hey, if you really need this appointment, you need to call back and book it at an appropriate time that works better for you.
Gotcha.
And then we note it, no-show. It's listed as a no-show. And then...
Do you use a smart set for the no-show EdCal smart set, or?
We don't, actually. So we just basically, when we go through here, when we do the contacts, each one is an outgoing call, and then we note every single time what the outcome of that is, if we have to do the 3 attempts.
Yeah.
And then the reason for call is no-show. It gives you an option to put notes there. And when we click on that, here, I'll just do it for an example. Under the comments, we'll put paperwork not completed.
Gotcha.
Because it'll show in the patient's, chart review that, they've had this phone call, but if you don't look deeper, you don't realize that they no-showed this appointment. So when you put it in the comments, it comes up, and it can be seen easily by us or by any other women's health facility.
Got it.
Okay.
Great. Do you have anything on that, Fiona?
I guess I'm just trying to think. So you wait until you actually have the patient on the phone to create the episode? Is that right?
Yes. Every single time, yes.
Okay. Because you don't want to have to go through and get rid of that episode if they do the answer.
Exactly. And it's deceiving. And when it comes to the clinic side of it, not a lot of people realize one episode from the other. Some people don't pay attention, those kind of things. Or once you resolve it, how to get it back, because that can you are able to unresolve an episode. So it's those little things. You're better off just waiting to open up the episode while you have the patient on the phone.
Okay. And then, just going back to the questionnaires, so the 3, it sounds like you kind of, you can all send your own emails, but there's a pooled way to get the message back to see whether the questionnaires were completed. But the piece of the past medical history, what were you saying? Like that you have to do something more manual to see it right now?
Right. So with the in-basket, you'd have to go into your in-basket, and then it shows the OB history update. It's a tab that can be clicked on. So with the in-basket, see how all of our in-baskets are attached? Unfortunately, I don't have one that I can show you as an example because everybody did their paperwork already. But of course, but there would be a section over by the folder summary that would open up, and it would give you the option to update history. And when you click on that, then we have a smart tool phrase that that was rolled out when they initially opened this up, because right now it's considered in the testing phases still.
Right.
Because they wanted to see how it would work and how it's doing, and it's been working really well. It's been making the phone call a lot more smoother when patients do their health history. So we would just have to accept it basically in order for it to populate in the chart.
I see. Otherwise, the other ones just automatically populate when you open the episode.
Absolutely, yes.
Got it. I see. Okay.
Correct me if I'm wrong. I think, Carla, you said that you can actually see the ethnicity base, the early start, and the genetic questionnaire in the chart, but it doesn't populate into the pregnancy episode until you create the pregnancy episode.
Absolutely.
Okay,
yes,
so
you are correct.
Can you show us where, say she had done those questionnaires,
how would I know?
Yeah, exactly.
Okay.
Where would you be looking for those?
Perfect. Okay, so there's two ways that you could do it. You could do it in the in basket, where I just was. It would show the 3 questionnaires that are done. Or if you look in the review snapshot of the patient and go under encounters, it would show, see how my name is right here, it would show that I sent out it would say, if I sent out the email and the patient did not fill out her forms, it would say, welcome to prenatal care, please fill out these forms. That's how I know the patient never filled it out, because my email is still sitting there. Now, if she was to fill out the forms and submit it, it would change, and under description, it would say questionnaire submission.
Oh.
So when you click on it, then it would open up and it would show all of her questions and answers, and you could look at it outside of actually opening up the prenatal encounter.
Right.
And a lot of times that's an indicator for us when we're clicking around and looking at the patient's history and trying to do our homework ahead of time. Say I haven't looked at my in-basket in the last 5 minutes, and she turned in her forms, and I didn't see that. When I see that it's been turned in, then that's an indicator to me to jump into my in-basket to make sure her history and everything is updated and ready to go for that phone call.
Gotcha. Great.
Any other pre-questions, Karen, that you had before?
No, I think that was mainly it. How do you know that she's actually done the questionnaire, so you're not looking foolish on the phone to say, by the way, did you get around to completing those questionnaires?
Right, exactly.
And then what are the other pre-steps then you do? You review the chart as well then, or?
We do. So usually what I do before I call the patient is I look under encounters, and I'll see if the patient's had a history of infertility. If she's had infertility treatments with Kaiser, because usually they're seen a bunch of times before they pass them on to Women's Health to be seen for prenatal care. I'll look to see if she's had any active bleeding, if she's had a dating ultrasound. There's lots of different factors because, even though the patient says her period was, July 25th, based on what the dating ultrasound says, it could be totally different, and I'll note that. And how I note that is just I have a separate piece of paper next to me with notes on the patient, where they want to be seen, what facility they deliver at, if they've delivered before. So I'll also look at their history. I'll click over on history, and I'll look at obstetrics. And this patient's had a ton of babies. So, I'll look at all of this information as well, and make sure all of that is correct. And we do review the OB information with the patients on the phone as well.
Okay, got it.
And then if the patient has also been seen in the clinic, there's times where we're really lucky, and the clinic has also booked that next 3I for the patient, the first initial appointment. So I'll click on hide additional visits, and I'll look to see if she has that appointment with the nurse midwife coming up, or if she has that follow-up appointment with the doctor because they didn't see what they wanted to see on ultrasound. So when I call the patient, I can say, well, I see you have this appointment scheduled on this date, or I see that you already have your first initial appointment booked, but I'm going to order that lab work for you so you can get it done ahead of time. And I'll let them know exactly when they need to go in to get the lab work done, so the labs are there for the provider to look at that initial visit. And then I'll also look at the lab portion, because you never know. Every once in a while you get really lucky and someone does all of the work and they've already ordered those labs for you. The provider has already done that, and so we're not going to repeat what's already been done. And I'll tell the patients, you know what, it looks like they've already done it and you went to the lab, so you don't have to worry about doing that as well. So it's just a matter of doing your homework and really sounding like you know what you're talking about before you jump on the phone and offer all these things that have already been offered to the patient.
Got it. That sounds good.
Okay.
Okay, and then you open the episode, I guess, is the next step, yeah?
So the next step would be contacts. We're going to call them, incoming, outgoing call, and you chart it appropriately. Reason for call is always new OB, unless they miss their appointment and it's no-show.
Got it.
And then I jump over to demographics. And when the patient answers the phone, I basically introduce myself. I tell them exactly what we're going to do today based on if they filled their paperwork out or not. I let them know I'll order lab work for them if they need it, because I've already checked that. And then I also let them know that we're going to book their initial prenatal appointment for them as well before we get off the phone. And then before I jump into all the paperwork and all that stuff, I verify their demographic information. So, we ask them current address, phone number that we called today. Is it okay for us to leave private voicemail messages on the line? And we'll note that under comments. And then we've been also dealing with the emergency contact list. And it's really good for two reasons. One, because half the time it's not updated, and say that person's ex-husband is still on there. That's always not a good situation. Yes. Yeah. And so we update it to what the patient wants. Now, usually if they're updating and putting their husband in there, then I can write down their husband's first name, so I'm not constantly saying father of the baby, father of the baby, a bazillion times. So it sounds a little bit more personal. Right. And that's just something that we've picked up here out of, putting your foot in your mouth a few times, or, listening to somebody else talking, and they're like, you think, wow, that process, that's really smart. I can save a step down the road by putting writing down the husband's name real quick, those kind of things. So then from there, I go to history, and I look at the OB history again. And I verify, some patients have nothing in their chart if they're new to us. Some patients have, it says, Gravata and then para 3, but it doesn't give us the details of each one of the births. So I just go through the process, and I ask, baby's date of birth, how far along were you? Was it a vaginal delivery or C-section? Just put it together a little bit better and cleaner for providers to look at and for people to be able to see and get the information that they need. So from there, then I ask the patient the first day of their last period. That's if they didn't fill out their forms, if I didn't get any information from what I was looking at with encounters, or if it says nothing. So under Epic here, it's really cool because we have what's called a pregnancy wheel. In the past, we used to have to look at those wheels that we had in Women's Health with the lines and always have to spin it and try to figure out the dates. But it's really cool here because if you put the information in, it automatically populates it for you. And then I jot it down, again, with my little piece of paper, and I tell the patient, you're roughly about this with the due date around here, but once we get the dating ultrasound at your first appointment, we'll find out a little bit better how far along you are, and if the provider needs to change your, dates at all during that appointment, they'll just let you know. So from there, then I go to OB dating and forms. So the first thing I do in my process is I look at the patient's OB, the past medical history or present medical history. And if the patient has filled out their paperwork, there will be a series of yeses in the yes column. See, like this? But patients don't have to click no on every single one of these, because if they click no on every single one of these, or if you're asking the patients the yes or no questions, and you're clicking no on every single one of these, this will come up inside the patient's medical, the history, where we just were. Sorry, this part right here. It'll come up as a bunch of no's, and it'll look like a bunch of just garbage everywhere. It just doesn't look good. So the only things that we click are the yeses.
And you're probably going to show us this, but say a common mistake that I've seen sometimes is with the chicken pox, where they don't know or it's confusing to them.
Right.
And so say you're on the phone and then you clarify, oh, she really did have chicken pox, but she wrote no on there previously. How do you correct? Is it the little paper next to it? That almost looks like a document. Is that how you edit or put comments?
Honestly, this can be edited even if the patient's filled out their paperwork. So
okay, so if she clicked no, and then
so
you need to click, then you need to update it to yes. Then you have the ability to override the previous.
Yeah.
Okay.
So if I was going to remove it, it asks you, do you want to remove this?
Okay.
And I click OK, and it gets rid of it, and it puts it to a no. But going to yes, it doesn't, it's not a big deal. It's definitely editable.
Okay.
Now, the one thing that I've told putting this out and rolling out this whole test prenatal medical history information. Now, say I reviewed this inside my inbox with my in-basket, and I accepted her medical history. For some reason, it never marks it as reviewed. It'll always say never or give the last day that somebody looked into this, but it will never give the information that was just populated. I know, and I wish, because when we cover in baskets, it would be nice to know that my coworker was the last one that put this. I mean, I know that it was done because I can tell it's been done by the way it looks in when you open it up, for one, and the encounter that we have to do and that I see under a review snapshot. It will say, so under encounter here, you know how I told you that it says questionnaire submission right here? It'll say questionnaire submission.
Yes.
So right above it, my name will be there again, and it'll say OB, history completed, update in history.
Okay.
So that's how I know that they've also filled out the history form. So I know it's been done, but for some reason with this form, it doesn't update unless you click it, and then it updates. See how it puts a date there?
Gotcha. Is the information still correct though? Wait, because you're saying that okay.
Yeah, the information is correct because either one, we know that the patient filled it out because she sent it back to me and I saw it.
Right.
Two, my coworker has done it, and again, I saw it by being able to review that she's filled out her forms because the information is there in her encounter summary. Or three, I'm asking her all those yes or no questions, one by one, going through everything if she didn't fill out her paperwork.
I see, but it's just that date doesn't update unless you do something to it.
Yes, the date doesn't update unless I've done something to it. Now, in order to also tell patient, in order to make sure that all of these patients' yeses are indeed correct yeses in their medical history, what we've been doing is telling patients, we see that you filled out all of your forms. I'm going to review these forms to make sure everything came through okay. And the first one I'm going to look at is your medical history. Now, I've seen that you've had an abnormal pap smear in the past. Say all of these are clicked as yeses, okay?
Right.
I'll tell them, I see that you've had an abnormal pap smear in the past, you've had chickenpox, you've had a history of hepatitis B, and you've also had herpes in the past, and a history of lung disease. Is that correct? And they'll say yes. And that's how I know that everything came through okay. Because I've had a patient before click HIV positive by accident.
Right.
And
right, that's what I was thinking.
Yes. So what I do is when I go through all of those, she's going to stop me and say, no, I've never had that. I must have messed up. And then I can just unclick it. It's not a big deal.
And on the patient side, say I get these questionnaires and I go in and I submit them, and then, I'm talking with my mom and realize, actually, I did have this when I was a kid or something. I did have 2 seizures, but I don't remember having it. Is there a way for the patients to go back and submit it again, or is it once they've completed their original questionnaire, then the further updates just come from us and they can't go back in and edit it, or does it keep a track? Like, say, the other situation happens where she says no, and then she confirms no with you on the phone, and then 3 weeks later she says, oh gosh, I better go in and update that.
It is not editable for them.
Okay.
They turn it in. Once they turn it in, they can't go back in and edit it again.
Just the healthcare providers can.
Just the healthcare providers, and usually what will happen is when I have that patient on the phone, they will say, you know what, I did have that seizure, or whatever, and then I can mark it as a yes. I can change that.
Okay.
And I always tell patients when we're going through things like this form or the genetic form or anything like that, I tell them if something comes up and you're having that conversation with your husband, especially with the genetic form, and you realize there's that one family member that had something, you can always let your provider know at the first appointment, and this is the form that they can change. It is something that can be edited, and they say okay.
Gotcha.
Okay. So from this point on, then I go into episode, and this is where I create the new episode, because episodes usually, not EED, EDD is 2018, for example, and pregnancy. And then we hit accept. Where the heck is that? There we go. Okay, so available forms is how it looks to us when we first start this process. So if I was to click on this, it's going to give me every single form that is available throughout their whole pregnancy. The only forms that we deal with are the first one here all the way down to pregnancy circumstances here. Everything else gets done with the provider when they have their care. And what I usually do is I start with pregnancy circumstances first, because you kind of get an idea of what to expect with the patient, because you never know.
Right.
So, we ask them, what is your living situation? Now, say her husband's name was Brian. Are you and Brian currently living together? Yes. Then I would click with baby's father. I would put in his name here. Is Brian the biological father? Is this a surrogate pregnancy? Will the baby be placed for adoption? And living situation and all this. Now, if any of this at any time is a yes, or an I don't know, or I'm not sure, then what I do as a courtesy is when we're done booking that 3I, is I send a Health Connect message to the provider that they're seeing, saying heads up. This is what happened during the phone call. This is what the patient may need, and I give the resources to, give it to the provider.
And is your heads up as part of do you put it in the routing comments for the OB telephone encounter, or do you send them a separate staff message, or how do you?
Separate staff message.
Okay. Just curious.
Yeah, no, that's okay. So then from there, okay, so you know what, let's accept this. So we accept it, and when I accept it, it's going to jump over here, and that's how I know that I did that form. So from there, I usually go to the ethnicity-based screening questionnaire form. And, the questions are self-explanatory. And we ask the patients if it's, donor, egg donor, and then we ask them their ethnicity. And then based on what they answer, we go through this. Now, say the patient wants cystic fibrosis because it's their very first pregnancy, then we give them the information on that and how we test for it, and it is a test that only needs to be done once in their lifetime because it never changes whether or not they're a carrier. And if they agree to it, then I click this. If they say, you know what, no, I don't want that done, then you're just going to click no to everything, because when we're done with the phone call, I'll show you where I chart whether or not they're going to get this done. So I hit accept, and then I go to genetics.
Carly, can I ask one question back on that? So if she had already filled that out, though, she had done the online questionnaire, this would already be pre-populated, and then you would just see those other boxes that said you want to order? Okay.
It would be like this.
Okay,
and so when
so
I
we'd already have a yes in there, and then the part here on the right would just be available for you then to indicate, it's kind of like a built-in prompt. She wanted this, so make sure that you go ahead and order it.
Yes.
But by clicking that, does that automatically place the Health Connect order, or that requires a manual entry?
Always a manual entry.
Got it. Okay, so you're taking notes probably on the side here again. Oops, here, yes. Yes, you want the CF.
And what I do usually, because I've been doing this for so long, is when I'm looking at this, and this form is very vague, and so patients don't even know what they're clicking yes for half the time. So then I have to, go back and say, I do see that you and Brian are Caucasian and that you indicated you wanted testing for cystic fibrosis. Would you like me to tell you a little bit more about that? Because I know our forms don't give you a whole lot of information. And usually they say yes. And again, then I go into the normal spiel of what I would say about cystic fibrosis.
And now, when you say your spiel, is that the information that's on the back side of that?
Yes.
Okay. Of that questionnaire?
Yeah.
Which is reasonable. It's not crazy detailed, but
no, it's not.
Some sense of it.
Yes, exactly, exactly. Now, a lot of patients say this is her third child, and she's still going to click yes because that's, she doesn't know if she's had cystic fibrosis done. She doesn't really remember. She doesn't know that she's supposed to, if she's going to have it more than once. Patients don't know that if they need to have that done over and over do is while she's talking to me and while I'm reviewing, I'll look under labs real quick and I'll click on genetics, and cystic fibrosis will pop up here if it's been done.
Okay. And do you know if you accidentally did order a repeat test? My understanding, and definitely correct me if I'm wrong, is that when the lab receives, they'll process the order. They'll collect the blood for that.
Oh, yeah.
But then once they actually start to go through to process it, they won't actually run the test.
So I have seen otherwise. I don't know how true that is because when I've opened up this section for genetics, I've seen patients that have had it done 2 or more times.
Oh, gosh. Okay. What a waste of money.
Yes, exactly,
Okay.
exactly. So if she's already had cystic fibrosis and I see it, I'll tell her, you know what, you've had cystic fibrosis done in April of 2011 and you were negative as a carrier because it doesn't show, and a lot of patients know if they're carriers. They'll know if they're a carrier.
Right.
Because it's talked about with their prior pregnancies. And you don't have to have that test again. So it's one less vial of blood this pregnancy, and they'll say, "Yay!" You know, they're excited because they don't like that initial blood draw with everything.
Right. Okay.
So and then once I get her off the phone, I will also note that in the problem list. That's where everything is noted, so the providers see it and they know as well.
Right. You put in antenatal screening and what tests were ordered.
Exactly. So from the ethnicity-based screening questionnaire, then we go into genetics, and again, if they've filled out their forms, everything will be filled out. Everything. You know, the S's, the No's, the first day of their last period will be there. If it's not filled out, then we have to go through every single one of the yeses and the no's. If anything's a yes, I offer the consult with genetics. And if it's a yes and they haven't clicked that little box right there, the consult for genetics will be offered to them. And then I explain to them, you know, it's a telephone appointment. They'll get some more of your health history, and then they'll determine whether or not that some additional testing needs to happen before baby's born.
Okay. And when you say you offer the consult, do you put in the e-consult referral for that, or you give the patient the number to call? Or
No, we put in the e-consult referral. So again, then I note on my little piece of paper next to me, e-consult. So it triggers me to do it when I have them off the phone. Everything that I do with them on the phone is everything that I'm doing with you right now is everything that I need to do while I have them with me.
Right.
Everything else that we do, you can get them off the phone. And you don't have to sit there and keep the patient on those dead, empty silences while you're trying to chart and do what you need to do.
Right.
So from there, I just verify now the early start screening questionnaire. If she filled out her forms online, this information will be completed. And then I would just hit accept. If it's not been filled out, this is the form that we resend to patients again with that follow-up email that's done at the end of the phone call. Because that is just one form that we cannot do with them.
And then can I ask, when you guys get positives in DSA on that, do you try to facilitate that their early start appointment happens at the same time as that first DOV, or?
No, we don't. It is very tricky because early start counselors have different schedules and different protocols, and we're already jumping around trying to schedule appropriately for the facility that has their own, you know, things that they want us to do and remember.
Right.
So it's up to the facility when they open up that patient's encounter, the prenatal OB encounter, when they're getting ready to make their 3I packets and stuff like that, for them to look and see that patient needs early start.
Okay, so they do that before the patient comes in, and then based on the local workflow, they may or may not outreach to the patient to say, we'd also like you to meet so-and-so this day.
That is exactly what our facility does here in Martinez, and I know that because I know how it works here. I couldn't speak for other facilities and how they do it.
Okay. A lot of moving parts to try to...
A lot of moving parts. Yes, exactly. And so each facility, basically, from end of phone call with us, it's up to the facility how they want to build the 3I charts as far as the first and second trimester screenings, get the information they need, early start information and all that. It's on the facility on how they do that. That I wouldn't know.
Yeah. And they do a 30-minute appointment for their 3I?
40.
Oh, they do a 40. Okay.
Mm-hmm. check delivery site for the patient. Depending on what they say, I just mark it, and then it moves over to the other column. And then I also check in to ask them, who do you prefer to see throughout your pregnancy? Who do you prefer to see when you go into women's health? A lot of times, if they're new, they don't know. They're open to it. A lot of times, if they've had babies before, they'll say, oh, well, I like, nurse midwife Beard or whatever, and then I'll note it appropriately in here. If they truly don't know, and I tell them, you know what, you have some time to decide. You can look online on kp.org at the physicians that have open panels and things like that. Then I'll just put unsure in the comments. And I'll click OK. And then everything is populated here. So from here, I'm ready to book their appointment. And when we book their appointment, I don't know how it would work regionally, but for us, it's done by midwives or nurse practitioners, and depending on facility, we search for appointments around 8 to 10 weeks of pregnancy. And then we give them their options, and when they choose the appointment, what I do, because once you book the appointment for patients, they tend to turn off mentally. They're like, oh, I got my appointment. I don't need to think anymore. I don't need to.
Right, I'm done. I got my get out of jail card.
Right, I don't need to retain anything else that you're saying. Everything else is like Charlie Brown's mom, blah, 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 blah. They don't care. Because we've tried it many different ways. And our process has always been the same in what we tell them, and we tell them everything they need to know, and whether or not they absorb it, that's on them. So what I tend to do is I tend to tell them, this appointment's done between 8 to 10 weeks of pregnancy. You're 6 weeks now, so I'm going to look about 2 weeks out into Deer Valley's schedule. This first appointment is about 40 to 45 minutes, so you can plan your time appropriately. And it's done with a nurse midwife or a nurse practitioner for this initial visit. And then after that, you can see Dr. Schroeder for the rest of the pregnancy if that's what you'd like to do. So they don't get really defensive and say, oh, I don't want to see this person. I've never seen this person before. I only want to. And you'll still get that.
Right.
But it's all in the wording of how you say it.
Yeah.
And when I give them that information, and while I'm looking for the appointment, I tell them, at this appointment, what will happen is the provider will look at your health history, which is everything that we put together in your chart. They'll also look at your lab results, because I'm going to have you do that ahead of time, and we'll talk exactly about when you need to do that in just a second. I tell them they're going to do an exam, they'll do the ultrasound, and then they'll discuss those genetic screening options for birth defects with you, like spina bifida, Down syndrome, those type of birth defects. And the information for that will be in that email that I'm sending you, and I give them all the information that's in that email and what they should be looking for in the email. And then once I'm done doing all that, because they're still listening intently because they want their appointment still, then I book their appointment for them. And so once we get the appointment booked, then it gives me a date to tell them they need to get their lab work done by. So say I booked that patient's appointment for September 26th. When I tell them they need to go to the lab to get their lab work done, I tell them everything that we ordered for them. And then I also tell them, no fasting's required, no paperwork from me, nothing special that you need to remember. You just need to show up and be able to use the restroom and have your Kaiser card. And I need you to do this labs by September 19th. So we always tell them 1 week before, if we can. Now, there are some special circumstances where the patient's 13 weeks pregnant and her appointment is at 3 o'clock in the afternoon and you're seeing her at 11. Obviously, she's not going to get her lab work done.
Right.
So, I always tell them you will go to the lab to get your lab work done after you're done seeing the provider. Because at that appointment, they're going to offer genetic screening for the patients, too. And if the patient decides to do it, then she can get everything done at one time. And it's convenient for them that way.
Do you get pushback from patients to say, look, I've already had 3 babies before. Do I really have to go?
Yeah, I used to a lot in the past, and then I thought about what I wanted to say and how I wanted to say it. So I tell patients, I know you've had this done before because you've had babies before, but we need to do it again for baby number 3. And I list off everything that we're doing, and sometimes even then if we get a pushback, I'll tell them, you know what, this is all, like, I know my blood type. You guys know my blood type. I've had this done before. I'm like, yeah, I know your blood type doesn't change, and I know that's silly, but it's done in a panel, and I can't pick and choose what I can pull out of it. Okay. And a lot of times they'll say, okay, and just do it. Okay. Sometimes if they continue to push back, then I say, you know what? You don't have to do these labs. You can discuss it with your provider at your first visit. And I put it on the provider to have that conversation with them in the office.
Yeah.
Because I'm not going to sit here and argue with you to get it
right.
done.
Right.
I'm going to try my best,
right.
and I'm going to say the things that might get you to do it a little bit easier, but you know, if you're not going to do it, you're not going to do it. And you run into that every once in a while. But for the most part, everybody's pretty agreeable. So, and that's it. Once we go through the lab work, I ask them, do you have any additional questions for me? Sometimes they do, and it could go anywhere from, do the doctors do deliveries at the site? How does that work? Who's going to deliver my baby? To questions about genetic screening, that they're going to get the information in their email. But, I'll help them out with that if they want any additional, information. And ultimately, the doctor is the one that's going to have to, accept or decline whether or not they want to do the genetic screening. Because some patients know, I'm 39 years old and this is my third baby, I want that NIPT. Okay, well at your first appointment, she's going to talk to you about that, and you can fill out the paperwork and she'll tell you exactly when you need to go in to get it done. So, things like that. It's just, it really just depends on the questions that you get. And then, of course, I tell them congratulations on their pregnancy. If they have any additional questions that they might have that might pop up, and it's just routine stuff, if they're on kp.org, they can email their doctor directly. Or obviously, if they have any issues, to give us a call, and we'll bring you in sooner for anything like that. But for the most part, it's a pretty easy phone call. Pretty standard.
And then, so how do you, say a patient's unimpaneled, whose name does the lab get ordered under then? Or
that's a good question. So labs always get ordered under the provider that's seeing them for the 3I.
Okay. So they're actually ordered mostly under your NP or your midwife?
Yes.
Okay.
Every once in a great while, when you call a patient, they will tell you they don't know their last period at all.
Yeah.
I've been breastfeeding, and I don't know. I just had my last baby a year ago. I'll still go through the paperwork like I normally would, because that patient's going to end up on our schedules again anyways. At the end of the phone call, I'll still order the lab work, but instead of ordering it under an NP or a nurse midwife, I'm going to, put those orders, place it under the name of the physician that I ordered, book their dating ultrasound with, which is usually if they're impaneled. They're usually impaneled. Very rarely are they not anymore.
Okay.
And then do you talk about your pregnancy website or centering or any of the other resources?
Yeah, so at that end of the phone call, when we talk about the genetic screening, I also give them information on prenatal classes. We offer to book the initial prenatal early pregnancy class for them. First-time mommies are easy to catch. Second, third time, they're like, yeah, no, I've done this before. I don't need to do this again. We tell them about the centering video that's in there and how they'll get more information at their first visit. It talks about, we also tell them, what I tend to do is I tell them, there'll be routine information in there, like medication questions, food questions, caffeine, exercise, because a lot of their end questions are questions about that. So as long as I wrap that into that email and what you're going to get out of that email, a lot of times it stops some of those questions, because a lot of those questions I can't answer. It's on the physicians to be able to tell them if they can still do CrossFit. I can't tell you if you can do that. Those kind of things. So, and if they have a specific question like that at the end of the phone call, then I tell them, you know what, you can send your doctor that message on kp.org. You don't have to wait 2, 3, 4 weeks to get that answer if you can still do CrossFit. That's a routine question that you can ask, because I know it's not going to be in the generic information that we're sending them when it comes to exercise and stuff like that. But yeah, the end of it is where before I book that appointment, I give them all that information on what they're going to get in their email, what happens at the first visit, and then I book the appointment and tell them about their lab work.
Okay. And just because, Karen, I had a question sort of going back to the beginning, but I don't want to what other questions you have at this point?
Honestly, my things are more like, what do you like about your job? What's the hardest part? What would you change? You seem very upbeat and like you're really happy with it. I'm just curious, the monotony of it, or just, the other challenges, clearly you would want them all to do their questionnaires and those things,
Right.
but just other stuff that provides you with job satisfaction and...
Well, it is a very monotonous job. I'm not going to lie. It's very easy. I've been doing it so long I can do it in my sleep. I would say the ideal world obviously is fill out your paperwork, but it's not the end of the world if they don't. We get plenty of time to talk to these patients.
You guys do 30 minutes?
Yeah, 30 minutes. It's 30 minutes. Every once in a while you get a patient that's really going to drag things out and you're on there. The translating patients are rough. Those are rough. Yeah. And we don't always know if we're going to have a translator. Say the patient's completely new to Kaiser and you call them and they speak Mandarin. And so you're having to backtrack and get that Mandarin interpreter and then call them back. So those take a little bit longer. Obviously, they take up to 40, 45 minutes. I think the longest patient I had one time spoke French, and it was almost a 2-hour appointment, and that's because she just was not all there. She's a little nutty. Wow. It was rough, very rough, to where I had to tag one of my other coworkers and say, hey, can you do these other patients? Because my patients, I was behind by then.
Yeah.
So but that happens once in a blue moon. Once in a blue moon you get that patient that's just non-compliant. And again, I'm not going to fight with you on this. Some of them, I've had one that didn't want to talk to me because I wasn't an RN. Just routine paperwork. Nothing was wrong with her. She just didn't want to do her paperwork and discuss her history with me. Okay, fine. So I contacted the facility, which was San Ramon, and I let them know, and they brought the patient in directly. And, I'm not going to fight with you on it. So for the most part, it's a pretty easy job. It's much easier than it used to be. I've been doing this since the patients used to come in front of us and do appointments.
Oh, gosh, how painful. Yeah,
yes.
For everyone.
Yes, absolutely. Because I had a patient last week, and she was having her 4th baby, and she said, is this because I'm older? She's 39. Is this because I'm older, or is this something that you guys do for your service area? And I said, it's something that's new that's been done in the last 2 years. Oh, okay, that makes sense. I haven't had a baby since then. And she was totally fine after that. And it's more convenient. I mean, granted, the one thing that's hard is that you do get a lot of patients driving in the car.
Yeah.
You can't hear them very well. You get kids screaming in the background, and you're competing with them. Patients ordering food, sitting at restaurants. I mean, you name it.
Right.
We've had it. Half asleep in the bed, and you're like, speak up, I can't hear you, in a nice way.
Right.
I can't, this is hard. So that would be the hardest thing, I think, is it's convenient for them, but it can be inconvenient for us.
Yeah.
Trying to get the information that we need.
Yeah, and you guys just use the language line for your interpreter services?
Yes. So once the patient's off the phone and I'm getting ready to do the rest of my charting, I literally tell everybody that I'm working with or whoever I'm training that I start from the top down. And that's how I know I've done everything. I double check myself. So I go into problem list and I put in antenatal screening. Her problem list is probably going to be gigantic.
Yeah.
So the antenatal screening, I'll put it in here. And let me find my pregnancy episode somewhere along here. Where did it go? Oh, there it is. Very last one. I'll link it. And then everything's done by dot phrases, so it's pretty easy. When you hit F2, it gives you the information. So this one here is for the physicians, the prenatal testing options. The ethnicity-based screening questionnaire is what we deal with. And it's pretty self-explanatory. So if I need to order it, and I'm going to order it for the patient, then I'll put in the information here, and it'll say cystic fibrosis, If the patient's had it done before, then I will put in patients had it done in, April of 2011, results negative. And if the ethnicity-based doesn't apply, then it doesn't apply. Or if they declined, hey, I don't want this, then they declined. So once I do that, I'll, hit my little guy here with the question mark, and DSA 1PNT is basically setting up the chart for the provider to chart in. So the patient made the following choices for antenatal screening, and I'll have that information there. And then I hit accept, and it's ready for the provider to review at that 3i. The information's there. Then I go into order entry, and I order my my stuff, my goodies. So prenatal order is the first one that comes up, and it's always prenatal order panel. UA, urinalysis, and then anything special. So, sickle cell trait, hemoglobin E, cystic fibrosis comes up. Select and stay, and you hit accept. So then it'll prompt you. I don't know why Jewish ethnicity always comes up, but it does for the labs. So you just click on carrier screening, and ethnic background, whatever she is, say Caucasian for now, and then I hit accept, and everything's there and ready. And then when I hit sign orders, I'm going to put no, and the diagnosis code is always the same, pregnancy counseling. It's the primary diagnosis code that we're using, and I click everything, I hit accept, and when I sign it, it's going to be signed under the provider that I booked the 3i with, or every once in a while that dating ultrasound with. So from there, I go into secure message. Say she was active on kp.org. Well, that's where I would send out my message about all that information that I was going to send her. So I would send it out, and then if she didn't do her early start screening questionnaire, I would reattach it to that, and then I would hit send. If she was 35 and over, I would also send the extra genetic screening options email for the NIPT information for the patient. And then I do a double check, and I go to OB dating and forms, and I just make sure, I look through here again, make sure I clicked everything I need to click on, make sure all these forms are here like they should be. Dating, the dating's going to be whatever her last period was, because once I put that in and I hit select EDD, it's going to populate up here, and I'd hit close. So she's 2 weeks pregnant. And then prenatal checklist. So what did I do for her? I ordered her labs. I went through the ethnicity-based screening questionnaires. We established what site she wants to deliver at. Sign up for the online newsletter. So that's basically me telling her about that information that she'll get in her email with the online information and all of our Kaiser's resources. And then early start, since she didn't do it, just to cover myself so everybody knows that I did what I needed to do, I always put sent here, because I always have providers that come back and say, well, they're not sending the forms out. They're not doing this. They're not doing that. So it doesn't show that I did it with her because I did not, but I did send it. And then I hit close. So then I go back into my telephone call, and I go into, if I can find my charting here, where am I going to chart? Geez, there's so much more stuff on here. Does anybody else see it?
Which one are you looking for?
To chart on the patient's information. I don't know if there is a section in here.
Check out like the document, and do you guys
Yeah,
put
to
anything in your
document.
progress note?
Yes, to document, yeah.
Yeah, it should be on progress note there. It's okay. I know what part you're talking about. So do you have a dot phrase that you put in?
Yes.
Like patient called
Yes.
or?
Yes, so we have what's called .lab, and we created that for ourselves here because the providers always come back. Did you tell them that, I wonder if it's under OB vitals and notes. Let's try, no, it's not. Did you tell them that they needed to go to the lab a week ahead of time? Yes, we did.
They just don't do it.
Right. Did you try to sign them up for that early prenatal class? Yes, I did. And so the .lab basically says I told patient every single thing that I'm ordering for them, and I told them to show up at least 1 week prior to their visit. And it also says I offered the early start, prenatal class for the patient, declined or accepted, booked or not, basically, and then we fill in the blanks there. Told patient about centering. And then the last one is early start questionnaire. Either it's sent, we sent it again in an email, they completed it if they did their forms, or we couldn't send it at all because they're not active on kp.org. So those are the 3 options.
What do you guys do for, I know it's a minority of patients, but are you guys doing do you mail out things, or you just wait till they come into the office? Or?
It really depends on the facility and how they handle it. In Martinez, I know that they handle it because the early start screening questionnaire, that blue form, the paper copy, that's attached to the 3i appointment, that 3i packet for patients.
Okay, so if they haven't done it,
If they haven't
when they
done
show
it,
up at the 3I.
exactly.
So it sounds like they actually personalize their 3I packet somewhat based on what they've seen.
Exactly.
Okay. And if the patients don't have anything unusual in their history, say, got a nice, easy multip patient who has nothing going on, do you route the encounter to the provider she's going to see, or you don't bother because
we leave
she's not going to do anything with it anyway? Okay.
So, and in the beginning, when the patient had like conflicting medical, in their medical history, how it would be conflicting. Say that patient had chlamydia in her history, but she didn't note it when she was clicking the yeses in the nose. In the past, what they would have us do is route that chart to the provider, or they got tired of that real fast.
Right.
They're like, yeah, no.
I'll figure it out when she gets there. What do you want me to do with it now?
Exactly. So what we do is we just confirm, it shows that you've had chlamydia or whatever, or high blood pressure in the past, and you click no, is that still correct? And sometimes they'll be like, oh yeah, I did have high blood pressure when I was pregnant or after I had my baby, but in their mind they don't consider it as being a history of any sort of high blood pressure, but it's noted in their chart.
Yeah. And do you do anything with their medications?
No.
Okay. So you guys don't touch meds at all? Like, you don't reconcile anything? Because you guys can't do that, right?
No. Yeah, we don't reconcile anything.
And you don't add anything, and you don't anything with allergies, or?
No, nothing with allergies either.
Okay. And anything with existing lab orders? Say you were to go in, you have a nice workflow because you go in and you see if there are any labs already ordered. I know you get the prompt if you try to order things.
Yes.
Duplicate orders and stuff. So you would just go in and remove the order, and just whoever it got ordered under, say it's not the clinician she's going to see, say I saw the patient and I've already penned it, or I've already ordered these things, but she hasn't done them yet, but then she's going to see, midwife Smith. Would you CC me on it, or you just figure, the midwife CC midwife Smith, or would you just leave it that, whoever's inbox it lands to is going to take care of it because they ordered it?
Usually that's what I do. I don't really mess with it too much because I figure if it's already there, I'm not gonna mess with who's getting what where, and there was a reason why it was ordered. A lot of times if the patient has labs that are there that say they saw the provider for that dating ultrasound, but the provider ordered labs to get their thyroid function checked or something like that, or something that has nothing to do with what I'm ordering, I will let them know you also have this order and you can get it done at the same time.
Right. Okay, and you don't do anything with those HCGs that have been sitting there from all their FERT evals and those stuff. Those are just there, and
we leave them there. Yeah.
Okay. Fiona, you have other?
Yeah, I guess I'm sorry. Somebody came in and out of the room, and I got a little distracted. But so for the people who don't have KP.org, then you can't email things to them. What are you doing for them?
We have a link to all of our pregnancy resources that they can look at without being active on kp.org, and while they're looking at that, I always give that little plug of sign up for kp.org. It's really great. And this is the reason why you can email your doctors. You don't have to sit on the phone through the call center every single time you have an issue if it's just a routine thing, those kind of things. And even if I add on there, and once you have your baby, you can email your pediatrician. They're like, ooh, yeah, they like that a little bit more. Because they're really not sure what kp.org is about. So I give them the link to our pregnancy resources.
So you literally tell them the URL by giving them the link.
kp.org/mydoctor/pregnancy.
Gotcha.
So.
But for people who aren't tech savvy at all, like don't have an email, and that's probably pretty rare in the pregnant population. But I wasn't sure if there's anything you send by mail. I guess.
No, we don't send anything by mail. No, usually we leave that on the facility to, if they want to do that, then they can.
This is totally my
So in general, somebody at least has an email address, but maybe not kp.org.
Right. Okay. Right.
This is totally my ignorance, and I totally understand. If you don't know the answer to this, say I'm Mandarin speaking.
Oh,
will it actually translate out the page for me? I know sometimes you can go to on Google, you search on something and you can translate. I have never looked to see if our resources get translated.
Okay, that's a great question. So we've been asking for 2 years to have it translated in Spanish. The most basic language that we send out and have to translate, it still has not been done.
Okay.
So everything's sent in English.
Yeah.
And even if, we're looking at the schedule ahead and we see that it's a Spanish-speaking patient, but they're active on KP.org, I'll still send those forms out because sometimes the patients recruit friends. The questionnaires, because patients sometimes recruit family members to help them. Or sometimes it says that they're Spanish-speaking, but they can speak English.
Right.
That kind of thing. There's lots of different variables, but unfortunately, and that's the thing, is if they're active on KP.org, I do have to tell them, I'm going to send this to you, but unfortunately it is in English. There is no other language that they've translated it to so far for us.
Okay.
Which part's not translated? I'm sorry, which piece are you talking about?
I'm talking about every single one of the pieces that we send out are all in English still, all of them.
Huh. Okay. I think you're right. Yeah. I'm trying to think about all the resources. And so wait. So it sounds like I might have missed an email. Karen? Did you receive like all the, in addition to the workflow, like what their dot phrases and everything looks like right now?
I haven't seen those. I was going to ask if you would be willing to share those just so we could see.
Right. So we got very lucky because our dot phrases, Health Connect came in and they fixed it to where it's just a one-click deal now. So we're not putting the .DSA, whatever. We're very lucky that we don't have to do that.
It's on your toolbar, or what do you mean?
It's on our toolbar. Yeah.
Wow.
Yeah. So let me see if I can pull it.
So wait, so your toolbar is personalized. As you sign in,
it's personalized to me.
Wow.
So up here, if this patient was active on KP.org and I'm getting ready to send out the forms for the day, what I tend to do, if I'm looking at my home, my home page of the patients that are lined up for the day, if they were all test patients, I would show you, I would hit jump, and when I hit jump, it's going to see my whole list of wonderful things that are populated for me, prenatal questionnaire. So this is the initial one that we send out. And it's really too bad that it doesn't have the KP.org linked, because it's going to tell me I can't send it to the patient, saying she's not active.
Shoot.
I know. So what it does when it opens that, it literally types everything in on the screen. Welcome to prenatal care. Please complete these forms. And then it takes each one of the forms and it plugs it in for you, every single one. And all you have to do is hit OK.
That's awesome.
Now what
so
I
you
do...
you all have the same ones because it's regional, or it's created for the DSA.
Yes.
Yes. Okay.
And what I tend to do when I go to review, so I'll click on review and it brings up the patient's chart, so I'm not clicking in the chart and getting ready to chart on her or anything like that. And while I'm here, I'll click on review to see if my coworker sent out those forms 2 weeks ago when the patient canceled her appointment and if they were done or not, or if my coworker sent out those forms 2 weeks ago but she never got a hold of the patient, but the patient completed her forms, because that happens every once in a while. Right. And so I'm not going to send out those forms again if she just had those forms sent to her. And usually it's not 2 weeks. I would say maybe 2 days ago. Say 2 days ago the patient missed her appointment and she's back on my schedule, and she was on Schedule D before. And I see that she filled out the forms, and Marcia imported those forms into her chart already, getting ready for the phone call, and she wasn't able to get a hold of her. So I'm not going to send her the information to do again. I'm not going to double do that to the patient.
Yeah, no, that makes sense. I mean, you obviously don't want to do that again.
Right, and also by reviewing and looking at this before you send out the paperwork, I also need to make sure she's not a teen, because a lot of times these teens have their parents as the proxies on their KP.org accounts.
Yeah.
So you have to look at that. There's a few different factors that we're looking at. I want to see if she's even active on KP.org before I try to send that email out. I want to see if she's a teen, and I want to see if it's been sent out already to her very recently. Because if it has and she's filled it out, then I'm not going to do it again. If it has and she has not filled it out, I will send it again. Because it's kind of like that push. Hey, there's something here that you need to do still.
But if they're a teen, what do you do then?
You leave it alone.
You don't send it, you mean?
I do not send it.
Got it. Okay.
Do you send anything to them after the visit either, or nothing
no,
ever?
I don't. Even if they say my mom, even if they're talking to their mom in the background, I don't do that, because you never know. You never know. Mom, quote unquote, might not be mom. Those kind of things. You just never know what situation you might get. And also in the ordering, you have to, change it to teen confidential
services.
Mm-hmm.
Yeah.
So can you send just regular emails to patients then?
I could if I really wanted to, yeah. And I've done that before with the first and second trimester screenings, if we get a call from Oakland, prenatal screening in Oakland, and said the patient hasn't done their, or if we get the letter, the reminder letter, patient still needs to get their second trimester screening done, I'll send an email to the physician so they know that the patient still hasn't gotten it done, and I'll also try to call the patient to let them know they have until this date, and sometimes I'll even try to email the patient, just let them know, if prenatal screening hasn't done it already, because a lot of times they do it as well.
I see. So what this is my ignorance a little bit. If somebody's not on KP.org and you're not sending them an e-letter, what are you sending them, or an email? What are you sending them then?
Nothing. We know nothing other than trying to look at their review before we give them a phone call, trying to get as much information out of their history as we can without physically talking to them yet, and then we just, when we call them, then we jump into everything and try to figure it out. And
for afterwards, do you get permission, like with all that information, with the genetic testing and congratulations, like, and et cetera, the video for censoring? Mm-hmm. How do you send that to people who are on KP.org?
That is the link, the KP.org, My Doctor Pregnancy. That information is available on there as well for the DSA.
No, I guess, and again, I think this is totally my ignorance, not understanding how this works. If somebody's not, you do the whole talk with them, mm-hmm. and you want to send the after email or after message, and they're not on KP.org. You can't send anything. Okay, that was what I was saying.
If the patient's not active on KP.org, your default would have to be to send a letter, basically.
Right.
Got it. Okay. I wasn't sure if there's an interim there somewhere. Okay.
No, there's nothing, and it isn't like you can, send the email. It could just be in her holding inbox, and then when she finally signs up on KP.org, that her inbox would then have the information. You physically can't. Mm-hmm. The system's set up so you can't actually send an email unless someone's active on KP.org. Unfortunately, I kind of wish there was a thing.
I know.
That said, because sometimes it's that they're locked out of their account and then it goes inactive.
A lot of times that's what it is that they're locked out of their account.
Oh, I see.
Yeah.
And there's nothing you can do on the call to correct that anyway then? Okay.
No.
No, they have to go through IT to reset their password and go through a verification process.
Right.
Yeah.
So it's just the call center who have those e-letter sort of concepts that they can send directly to emails then?
Right, because those are non-secure. Those are generic things like, it's just like when you get the PD Well-Check questionnaire, that it's like, in order to prepare for your upcoming appointment, but it doesn't have anything that is pertinent to you or any kind of medical information.
Got it. Okay.
Yeah.
Just checking.
Yeah, it's too bad. It would be nice if there was something,
Oh, definitely. It would make things a lot easier on the patient side and then our side, too, because you're leaving them with this link hoping that they look for the information that they need to find. And,
right, and then within that, they need to know, where do I go to find that video?
Yeah.
Mm-hmm.
That's
Exactly.
All right.
Okay.
I think those are all the questions for now.
Yeah, exactly.
So what is the thinking behind it? Are you guys putting it, for Northern California? What regions are they going to try to roll this out at?
So we are looking at, there are a number of sites that don't have any kind of telephone appointment visit.
Wow.
And so they are really struggling because they're literally having patients come into the office and their providers are doing all the work that you're doing.
Oh my gosh. Okay.
Yes. And you can imagine, that it's not a very big satisfier for patients or for physicians.
Absolutely.
But they just haven't had the bandwidth to even think about, how they do it because everyone's kind of so siloed.
Yes.
And so there are places where, the patients come back several times and they haven't, done all the amazing work that you guys have done to figure out, this would really make a lot of sense and stuff. Mm-hmm. So trying to help them understand, what can be done, and especially, sites where there are, a whole bunch of satellite facilities and stuff. You guys have tons.
Yes.
You guys have figured out how to centralize it, but how do you don't want someone with only 3 providers, having one or two folks doing it, because that doesn't make sense, but you also can't just have one person to rely on her to do everything.
Exactly.
And stuff. So it's trying to learn what's working well and help those facilities that just haven't even started. So, there are a bunch of centers that haven't even tackled what you guys have tackled, basically. Yeah, which is sad, for everyone, because there's definitely more efficient ways of doing it, and and then there are still places that are still doing it the old way of, come in, sit in the office with me for 45 minutes with those 3 kids running around, and you took off work and stuff, and obviously those patients are very dissatisfied. So even if they have help, it's not necessarily the ideal way to do it.
Right.
So we really appreciate you sharing.
No problem.
Yeah, how you guys are doing it. It's clear you guys have put so much time and effort and have really refined the workflow amazingly.
Well, it's, just a total process of what works and what doesn't, and thankfully we work together really well. And,
it's clear. Yeah, that there's a lot of teamwork.
You'll always have the outside things like the facilities that, not everybody's in agreement. Some providers have complain more than others.
Right.
But for the most part, our process is streamlined. What they do once you get to the clinic portion, it will be a little bit different pertaining to each clinic, and how that would work out for them and what would work best for them and what their process is. So.
Right, but you guys have laid the foundation, and so they could really focus on their part and not be going through all these questionnaires and updating the chart and all those things. That's really it's extremely time consuming and really, not satisfying for patients either to sit there while that process is being done.
Right, exactly. I agree.
Yeah. Well, great. Fiona, anything else that you want to ask?
No, I think that's it.
Well, thank you so much for
You're
sharing.
very welcome.
Really appreciate it. You guys have done some amazing work. I wish everyone was doing it this way.
Right. Eventually, it'll happen.
It will happen. I mean, that's the thing, is it's like everything else, little flowers and gems spark up and other people start taking note and say like, wow, this makes a lot of sense and stuff. Why didn't we think of that?
Exactly. Well, good. I'm glad I could help you, and just let me know if you guys need anything else.
Great.
All right,
Thank you so much.
All right, you're welcome.
Okay, take
All right,
care,
have a great